pipeline session, which is the closing session of the meeting. As you probably guessed, I am not Kitty Clarence-Smith, but I'm glad to try to fill in for her. The pipeline sessions historically at the ASENT meeting have been the product of Kitty's efforts, and specifically in identifying and bringing in new developing products for presentation at the ASENT meeting. So she has been ill, but is doing very well and hopes to be at the meeting next year and out and about a little more in the next few months. For purposes of timing here, the presentation should be about 10 minutes, which will leave about 7 or 8 minutes potentially for questions. We have 5 presentations over the next 90 minutes, so it should be a fairly comfortable opportunity for casual discussion, which we of course encourage. So the first presentation is by George Farr from Aeromics. It's aquaporin 4 inhibitor, AER271, reduces cerebral edema and improves outcome in clinically relevant models of CNS injuries. George?
Thanks, Tom. So wow, last day, last session. I just wanted to say thanks to everybody for being here and sticking it out and being willing to listen to our story. So as Tom said, I'm George Farr. I work for Aeromics, and Aeromics is a small startup company, and we're really dedicated to taking advantage of aquaporin biology to treat life-threatening diseases of water imbalance. So what I'd like to present to you guys today is basically an anti-edema strategy targeting aquaporin 4 for the treatment of acute ischemic stroke. I'll cover the discovery and development of Aeromics 271, which is an effective inhibitor of AQP4, and I'd like to give you a brief outline of an ongoing phase 1 clinical trial that we're conducting with Covance, basically to look at the safety and tolerability of Aeromics 271. So the target indication is an acute ischemic stroke, and as I'm sure you are all familiar, you have an obstruction of one of these blood vessels in the brain that leads to hypoxia in the surrounding tissue. As a result, there's a loss of energy, and there's an accumulation of cations and metabolites that result in an osmotic imbalance, and that can lead to, in severe cases, gotta go back. Sorry about that, a little quick on the trigger. Really significant cerebral edema, including a midline shift. And if this is left unchecked, cytotoxic and ionic edema can give way to hemorrhagic transformation, giving vasogenic edema. You can get significant herniation down into the brainstem that then results in really a life-threatening situation. So if you take a look at this process at a more microscopic level, what I'm depicting here is the neurovascular unit, and we have astrocytes with their end feet reaching out to a blood vessel. And so these are the astrocyte end feet that are surrounding the vascular endothelial cells. And with that osmotic imbalance, once you have reperfusion, you get swelling of the whole neurovascular unit, so everything's swelling. And I'd like to just draw your attention to these little blobs that I've depicted here, basically at the interface between the astrocyte end foot and the endothelial cells of the blood vessel. And this is basically depicting aquaporin 4, which is massively expressed in the astrocytes, and at the astrocyte end feet form large orthogonal arrays, which I'm going to show you in the next picture. Coming up right here, you can see these sort of rectangular pieces. This is a freeze fracture of a rat astrocyte end foot, and it turns out that aquaporin 4 represents something like 35% of the total surface area of an astrocyte end foot. So it really is massive expression. So the idea is relatively straightforward here. At a molecular level, you've got this movement of water through aquaporin 4 into the astrocyte end foot and carrying on into the brain. And regardless of what the the source of the osmotic imbalance is over here, whether it be sodium or metabolites. That one final common pathway of water movement into the brain goes straight through aquaporin 4. So quite simply, if we could just develop an inhibitor that blocks, oops, this thing's getting a little sticky, guys. All right, so I'm going to hold it out. If we could just develop a blocker, an inhibitor of aquaporin 4, we could prevent that swelling or prevent the movement of water and thus prevent swelling. Oh boy, here we go. Sorry about the technical difficulties here. Okay, so target validation. So, the way that we really understand that aquaporin 4 is really a great target for cerebral edema came from the aquaporin 4 knockout mice. And this is the work by Jeff Manley and Alan Verkman. And what they found was that the primary, well, first of all, it was amazing that these animals survive. You can knock out AQP4 altogether. But the primary phenotype that they observed really didn't come until you challenged the animals with some kind of CNS injury. So these guys did remarkably better, reduced cerebral edema and improved outcomes in ischemic stroke, water toxicity, bacterial meningitis, so forth. So in this seminal article here, back in 2000, they looked at water intoxication and an ischemic stroke with the knockout animals. And so water toxicity is really a pretty severe model. So you basically inject the mouse with 20% of its body weight in pure water. So you're taking 6 mils of water and putting it into injecting it intraperitoneally into a 30-gram mouse. So it's a massive water load. And so the resulting hyponatremia, gives rise to, global brain swelling. And within 5 minutes, these animals are moribund. And this is basically a Kaplan-Meier diagram showing the percent survival. So the knockout mice do considerably better than their wild-type counterparts. And likewise, in an ischemic stroke model, and this is an intraluminal filament insertion to block the origin of the middle cerebral artery, the knockout mice, again, there's reduced swelling, and you see really remarkably improved outcomes. There are a couple of deaths here in the case of the knockout animals, but for the most part, you're really not seeing animals progress much past this point where they're circling to the left. Okay, so how do you develop an aquaporin 4 inhibitor? So I want to show you guys the cell viability, or the basis for the cell viability assay that we developed at Aeromics. So the idea here is that we've taken your average garden variety CHO cell, and we've developed stable isogenic strains with a control protein, membrane protein CD81, and aquaporin 4. So what we're going to do is we're going to show you, a video where we've compressed 8 minutes down into 19 seconds, right? So it's very rapid. And what we did was we removed the media and we replaced it with pure water. So severe hypotonic shock. So we'll start off with CD81 here. And if I just click the movie, what you'll see is these cells begin to swell. Maybe you see 1 or 2 will burst. A couple of them maybe will fuse with their neighbors, but for the most part, they remain intact. They become very turgid. And you can take these cells and add a 2x volume of 2x PBS to rebalance the osmolarity, and they'll shrink back down again, and they're perfectly viable. I'd like to draw your attention now to the AQP4 example and really focus on it because things happen very quickly when we replace media with water. Very quickly, they all just burst. They just pop. And so this really formed the basis of our high throughput screen. It's a very binary assay, and we look for cell viability. It's also very severe. So because time is short, I'm going to go through this pretty quickly. We screened a whole bunch of compounds. We got some nice leads that had good activity. We basically rescreened them to verify the activity in the assay. We did a bunch of validation assays. We found a very promising series of phenylbenzamides in the initial screens. We did a bunch of structure-activity relationship analyses of an early lead that led us to this compound here that we'd like to refer to as Aeromics 270. And we had enough structure-activity relationship work that we were able to really kind of piece together the key elements that affect the biological activity of the molecule. Turns out that this molecule is relatively insoluble, so we really needed to have a strategy to improve the solubility so that we could dose at higher levels, like what we might need in a stroke model or in the stroke clinic for that matter. And what we decided to do is this phenolic oxygen here, we added a phosphate to it to improve the solubility. So this goes from about, at neutral pH in saline, this goes from about 3.8 micrograms per mil to more than 4 mgs per mil. So it's a great improvement in one shot. And endogenous phosphatases are able to remove this phosphate and get you back to the parent drug. So this drug is active, or this compound, I should say, is active in terms of blocking AQP4, and the prodrug is not. So we're kind of fortunate with Aeromics 270. It showed us, pretty decent selectivity for AQP4 versus the two sort of closely related aquaporin 1 and aquaporin 5. So we had good specificity and also really good cross-species activity. Going from human to rat to mouse. And that makes sense in terms of the cross-species activity because these guys are really greater than 95% identical in terms of their amino acid sequence. I'm sorry a bunch of this stuff got compressed here, but to make a long story short, we did a bunch of sort of initial in vitro screening to look at the toxicity, and we basically settled in on these two guys here as our sort of lead compounds. So we turned to the animal models, and we started off with the water intoxication model, and of course, I shouldn't say of course, but quite remarkably, we saw results pretty similar to what you see, what was previously seen with the knockout animals. You see that here. We saw a very similar result here. This is roughly, it's a little bit more than a 3-fold improvement in terms of survival. If we look at swelling of the brain, we did this with MRI. We were able to do some rapid MRI scans and follow the time course of swelling in this water intoxication model. And we saw a reduction in the rate of swelling. And we saw some pretty good exposure of Aeromics 270 in the plasma in the context of the water toxicity model. So improved outcomes, to be sure. We got a nice improvement in survival, and as a result, apparently, of reduced brain swelling. So we turned our attention next to mouse ischemic stroke model. We did a transient MCA occlusion for 60 minutes. It was then followed by 24 hours of reperfusion. Again, to make a long story short, we did a low dose and we did a high dose. At the low dose, there was really no improvement in terms of reduction or prevention of cerebral edema, no real change in the neurological score. But at a higher dose, and in this case, we're just giving an IP injection, 5 mgs per kilo repeatedly over the course of 24 hours. We got a decent exposure of Aeromics 270, and sure enough, almost a 3-fold reduction in the degree of brain swelling and a nice improvement in terms of neurological outcome. So we decided to move on to a larger animal because we really wanted to look at this drug in terms of administering it with an IV infusion, so a continuous infusion. And so we moved to rats. Again, a 1-hour occlusion. We didn't begin dosing until 2 hours later, so there's a nice delay in the dosing. And then we let the animals go for 2 days. And here we've got a whole dose response curve that I can show you here, where we've gone from very high doses down to relatively low doses. Again, long story short, there was a nice improvement in terms of reducing cerebral edema and improving neurological scores by a modified Garcia score. The main point I'd like to point out here is that we had a minimum effective dose in terms of a maintenance dose of 0.03 mg per kilo per hour. So during the process of all of this work before there that I've been talking to you about, we actually interacted with a couple of independent labs, one at the Cleveland Clinic and one at the University of Pittsburgh Medical Center, that looked at a couple of different models that really depend upon AQP4 for edema of tissue. And we gave them Aeromics 271, and they tested in their models, and Aeromics 271 bore up under that test and showed good activity reducing edema and improving outcomes in those a couple of independent models. And so we really settled in on Aeromics 270, Aeromics 271, and went ahead and did the preclinical safety tox work. We did the work with Covance, and we looked at both rats and dogs. The drug was very well tolerated in the rats, and in the dogs we were able to find some target organ toxicity. There was a little bit of an issue in the liver, but that meant that we had some nice things to follow once we switched over to human. We filed an IND. The FDA was amenable to us proceeding forward, and we commissioned Covance to conduct a phase 1 trial to look at basically the safety and tolerability of Aeromics 271 in healthy volunteers, because this is a new molecular entity. We really had to focus on healthy volunteers. And so in the first part of the study, we did a single ascending dose. We had 6 cohorts. It was an adaptive design. We basically also did sentinel dosing, where you just take 2 of your subjects in the cohort, 1 with placebo and 1 with the drug, administer the drug, and wait for 24 hours and look to see if you have any adverse events. If things look clean, then you proceed to the remaining 6 subjects. And so we worked our way slowly up here to the highest dose. We then switched over to multiple ascending dose, and in this study, we had 3 cohorts, and we had 2 different types of treatments. We did twice a day bolus injections, and we also did 3 consecutive days, and we also did 3 days of continuous infusion. We then did a washout period, and then we did a crossover and switched the 2 groups. And then we would sort of slowly work our way up. But we also did the same sort of sentinel dosing approach. So we kind of put your your toe in the water, test the water, make sure everything's looking good, and then commit to the remainder of the group. So we finished our last subject dosing about 2 weeks ago for this last cohort. And we have not yet locked the database, and we certainly don't have a clinical study report yet, but I can report to you that we've completed everything, all of the in-life portion of the study. We didn't really see any major significant adverse events, and we achieved all of our targets, and that final clinical study report should be due sometime in July. I can tell you at this starting dose here in the MAD study that the sort of plasma exposures that we were getting were at or above what our projected human efficacious concentration is expected to be. So in going from here to the highest dose, it's about 10-fold, and so we got some pretty decent headroom for working our way into a phase 2 clinical trial. So just really quickly, in a way of summary, hopefully I've impressed upon you an anti-edema strategy for treating stroke, that we've developed a nice prodrug system that targets AQP4 and prevents cerebral edema, especially in the case of these sort of severe edema models. And we've got a nice outline and ongoing safety and tolerability trial, looking also at the pharmacokinetics of Aeromics 271 in healthy human subjects. And last but not least, I just want to thank the ASENT organizers, and especially the Abstract Review Committee, for allowing us to tell our story, our collaborators at CASE and the Cleveland Clinic, at Buffalo State, the whole Aeromics team, and last but certainly not least, I should mention that the NINDS really contributed significantly to our success in providing that SBIR funding for the discovery and development of Aeromics 271. Mm-hmm.
I may have missed it, but it looked like the vehicle group in the right-hand column, the Garcia scores. It looked like the vehicle group had a gradually escalating score, and the delta between the two didn't seem quite right to me. Am I misinterpreting that column?
No. So actually, the delta between the two is correct, and we definitely saw some significant differences. But we really kind of struggled with a little bit of drift in the vehicle control, in particular, in terms of the Garcia scores that we got. This was a pretty large study with lots and lots of animals that happened over the course of multiple months. And we had a little bit, and we didn't do all of these doses at the same time, which would have been great. We sort of interdigitated them. And so there were a couple of the doses where we had a little bit of a drift of the vehicle control to higher scores. And so that's probably what you're picking up on.
So given the room you have to work with from what looks like a minimum effective dose up to higher levels, do you have any sense of strategy for advantages or disadvantages of bolus versus continuous when you get into trials with people who are sick?
Yes, definitely. I mean, so I think my preference is, and it's probably because of the way I was taught pharmacology, is to really kind of focus on, when you can, to do a continuous infusion as opposed to bolus dosing, because you don't have the peaks and the troughs, right? You have a nice, steady, maintained concentration. And it turns out that, certainly in the dogs, we saw some significant issues where if you spiked too high with the concentration of Aeromics 270 in the plasma, you got into problems. So our sense is that we would probably lean very heavily towards a continuous infusion approach.
Do you have any sense of what toxicity might look like?
Yeah, so it was. We saw some in the dogs. We saw some liver toxicity, for sure, and so that gave us, a major heads up. And so we monitored, AST levels, ALT levels in the plasma when we did the phase 1 study, and I can tell you that we saw no effect. So. And we also, to be fair, we also saw no effect in the rats in the preclinical study. So I guess in the context of Aeromics 271, humans are more like rats.
Thank you very much.
Thanks.
Our next presentation is by Dorothy Ko at Genervon Biopharmaceuticals. GM604 regulates developmental neurogenesis pathways and the expression of genes associated with amyotrophic lateral sclerosis. Dr. Ko.
Thank you very much for the ASENT organizers inviting us to make this pipeline presentation. Actually, I changed the title. Since we have 2 posters, there was the poster in the yesterday. One poster is on the original title. The GM604 regulates developmental neurogenesis pathways. And the other poster is on GM6 attenuates Alzheimer's disease pathology in APP mice. This is pretty much an update of this pipeline, GM6. We call it GM604 for the indication of ALS disease, but they are the same 6 amino acid peptide. "20 years ago, Genervon believed to deal with CNS disease, you need to have a multi-target approach because CNS diseases are so complex. You involve neurosurvival, neuroprotection, when you need to modulate the immune response and so forth. So how do you do this multi-target approach? You can do it by mixing, combining single drug target drugs, but then you will have the drug-drug interaction problem. So we think maybe there is something, a regulator from within. So we started out looking for it, and we identified it, isolated it, and we found it about 20 years ago. We call it motor neuronal trophic factor, MNTF. And after we found it, we humanize it, clone it, get the sequence, and also get the monoclonal antibody. It was by using the monoclonal antibody, you can stain from these different placenta from abortions or at different weeks. And you notice at the week 9, the antibody stain the highest expression of this MNTF. And it is gradually lower and lower, and by the time the baby is born, it is almost gone. These are human placentas. This is done in China. This is the only experiment done outside of the United States. But this is very interesting. And later on, this is the original MNTF. It's a 33 amino acid peptide. And we later on can see that not only is expressed in brain, in the fetal panel, the highest expression is in thymus. And that brings us the idea that maybe the immune system really play an important role in these CNS diseases. And in the adult, that's the very low expressions. Then we feel that to really develop into a drug, 33 amino acid peptide is very big. So we try to make it smaller, and we use in silico analysis to find, and we isolated a small fragment. This is a 6-fragment amino acid, and we repeat the experiment, the functional test in animals, and it repeat the same. It can do the same thing, the same neuroprotection, and the same axonal regeneration in the animal model. And then we want to see, will this 6 amino acid not only work in peripheral nerve, can it also work in central nervous system? And we did an experiment in the mice, IV injection, and 4 hours later, we take out the brain and homogenize it and detect it with the anti-GM6 amino antibodies, and we see that it can be detected and it's much, much higher than without. And so with that confirmation, we moved on to see what does it do. And there is a general consensus that in the CSF of central nervous system disease patients, their CSF are toxic. So we use those CSF to culture with cortical neurons from rats. Courtesy of UCLA Spine and Brain Tissue Center, they send us all these free samples of CSF from their collection of. And as you can see, this is from healthy human subject. When it is exposed to the CSF, then they lowered. Say like all this with human healthy subject, it's pretty much there, but with the MS CSF or patients with AD or patients with PD, look at how much lower all these cells are. But when we protect them in the culture, if we put GM6 in there, you see that the number of cells are much higher. And they increase, like in the case of ALS, 175%, in the case of MS, about 246%, in the case of Alzheimer's disease, is 191%, Huntington disease, 273%, and Parkinson's disease, 198%, in stroke, 205%. So this is very encouraging. And then the next step we did is we move on to animal studies. And we did many different animal models. We did animal models in stroke, in Parkinson as well, but because of the time, today we only focus on ALS and AD. This is I apologize for all these very tiny fonts, but if you would like to give me your email, I can send you this slide, then you can enlarge them on your computer to look at them more carefully. It increases survival. The start of onset is in a dose response rate. You can see that the age of onset and the age of survival is extended in 5 milligram per kilogram is much extended. And you also see that the number of cells are preserved, and also later on, this was done many years ago, and then last year, we repeated the ALS SOD1 mice experiment because we did the APP model in Alzheimer's disease, and we found that GM6 lowers the inflammation markers. And so we repeat using the brain and spinal cord tissues, and we repeat the experiment with the SOD1 mice. We see that also GM6 also reduce all these inflammation markers, and as well as reduce the SOD1. The GM6, with the encouraging animal studies, started filing INDs with FDA, and we have several INDs with FDA. The one with, we finished phase 1, which is, we found it very safe and well tolerated. And based on the phase 1 results, we did the phase 2A study for ALS. It is a small trial with 2 sites. The safety profile is similar to the phase 1. It's very well tolerated. No adverse events that were drug-related. And we have some observation in the clinical benefits. And I want to point out especially the FVC, which is forced vital capacity. The patients will have to use a special device and breathe in and then breathe out very strongly, and then measure how well they can breathe out. Normally, average, this is the historical number. They have a lot of historical numbers. For FVC, historical number for ALS patients, they lost their FVC capacity by 3% a month. So this study is, we dose the patients for 2 weeks, Monday, Wednesday, Friday, Monday, Wednesday, Friday, and then no more dosing. And then we take measures at the end of, at the baseline, at end of 2 weeks dosing, at 4 more weeks later after no more dosing, and 10 more weeks later with no dosing. And we observed that the end point is at the end of the 12 weeks since the beginning. In the FVC at both sites, you can see that after the 12 weeks, the placebo is minus 11.5. The treated group is minus 4.7, which is about half of 9. So we see that it has a trend of slowing down the deterioration of the patient's FVC ability. And surprisingly, if we look at site 1, it even has statistical significance. And with ALS-FRS, we also see a similar trend that in the placebo group, it's minus 10%, and the GM6 in the treated group is minus 7%. What is more interesting is we use biomarkers to see what's the pathophysiology look like after the treatment of GM6. SOD1 is well known in the ALS disease, and we noticed, interestingly, in all the ALS patients, almost all the biomarkers are higher than normal. So the SOD1, at the end of 2 weeks dosing, the placebo group is about here, and the treated group is lower. And there's statistical significance, as you can see from baseline to after visit 1, after the 2-week dosing. The treated groups are below here, the line, and the placebo group is continue to go up. There's statistical significance in these 3 biomarkers. The tau, instead of seeing the difference at the end of 2 weeks, you see the difference at the end of 6 weeks, which is 4 weeks after there's no more dosing. And with TDP-43, there's a continuous slope, and we calculate, this is a post-hoc analysis, the slope of the change, percentage change in the slope, and the treated group, the slope is minus 3.5, and the placebo group is positive. And there's a difference of about 30% difference. And the p-value is very significant, is 0.0078. So this biomarker are very interesting results. And it leads us to think, because Alzheimer's disease has not been successful with testing beta amyloid or using antibodies of beta amyloid to reduce the beta amyloid. And people have been exploring perhaps lowering tau is one possibility. And another thing is there has been a lot of paper about TDP-43 in Alzheimer's. About 50% of the Alzheimer's patients have TDP-43. And that has been shown that it is associated with in the autopsy of the AD patients, it's associated with the shrinkage of the atrophy of the brain and also the dementia symptoms. So we thought that maybe we should look at the animal models with GM6 treatment on the AD animal model. So quickly, so this is the mechanisms we found in the ALS. This is the paper poster we put out, which is already published in here. And the main mechanism is neurogenesis. And the second mechanism is anti-inflammation. So in the APP mice model, well, FDA, since last year, most of the major pharma are getting out of Alzheimer's clinical trial. FDA has published a new guidance to move Alzheimer's to early AD and use biomarker, encourage people to test biomarkers. So in this animal study, the APP mice do not develop any plaque until 3 months later. So we use this model and start dosing it for 4 months. And after 4 months dosing, we notice the plaques are less, and all these miscellaneous, so many different inflammation markers, TNF alpha, TNF beta, IGF, and IL-1 beta, and so forth, and also increase of NGF in the brain. So we saw that these, also clinically, the water maze functions is improved, and so we saw that the two are very similar. So this is our conclusion, that almost 50% of the patients with AD also have deposition of the protein, TDP-43, in their brains. So we want to investigate, because in our phase 2A clinical trial, the patients, ALS patients, they showed lowering tau and TDP-43 protein many weeks after the absence of GM6. And so GM6 may also lower tau and TDP-43 biomarker to reflect the underlying AD pathophysiology change. And GM6 lower the similar inflammation biomarkers in both the ALS and the AD mouse models. In the case of SOD1 model, GM6 reduces the SOD1 protein, and in the AD-APP model, GM6 reduces the amyloid load. So it looks like lowering the protein aggregation is a common feature as well. So in conclusion, Genervon's direction with this GM6 is GM6 is phase 3 ready for ALS and phase 2 ready for AD, and we are interested to partner with pharmaceutical companies to move forward. Thank you very much. If you would like to, I missed one thing that's very interesting. Let me go back. here. I want to point out, after the phase 2A clinical trial and data log, and a year later, there was a Japanese journalist whose cousin has ALS disease. And he came to America to look for what else is there that can treat ALS. And he heard about our trial at Columbia, and he interviewed one of the treated patients. This is 1 year after the patient received the drug. And he went to interview him, and this is the link that you can click and watch it. I cannot show it here because I don't think we can show this video, and it's a 7-minute video. But if you get the slide presentation from me, then you can click on this link and watch it. And he was still 1 year after, the doctor told him you have 2 to 5 year life to live. And 1 year after the dosing, he was still able to walk up and down the stairs, and he was still able to hold a very heavy torch. So I want to point out this is a very interesting thing. Thank you very much.
Thank you very much, Dr. Ko. As we're running late, we'll have to skip questions here, but I'd encourage any of the audience to have questions to contact Dr. Ko directly after the session. The next presentation is by Margaret Lee, Dr. Margaret Lee at Cavion Incorporated, Proof of Concept, Double-Blind, Placebo-Controlled Study for CX-8998, a state-dependent T-type calcium modulator in essential tremor patients, efficacy and safety results. Thank you, Dr. Lee.
Thank you very much, and I'd like to thank...
10 minutes, we'll have time for questions.
Great, I'll try to do that. Thank you very much. I'd like to thank the organizers for the opportunity to tell you today about our study in essential tremor. I don't have a disclosure slide, but obviously I'm an employee and option holder of Cavion, and I would like to present this work on behalf of the TCOM study investigators. So what is essential tremor? Essential tremor was originally thought to be a benign disease, but it is very much not benign. It's actually one of the most common movement disorders. There's an estimated over 10 million people affected in the United States and perhaps 42 million worldwide. It's not a disease confined to the elderly. It actually, many of the patients in our study and others we're aware of were diagnosed quite early in their teens. It ranges from a mild shaking to a really severely debilitating disease that can significantly affect activities of daily functioning of patients. And it's also a source of social anxiety and phobia, and many essential tremor patients actually have comorbid depression and anxiety. So there's not a lot out there to treat essential tremor. The current first-line therapeutics include drugs like propranolol and primidone. Propranolol is the only drug approved in the United States for the treatment of essential tremor. It's, as you know, it's Inderal. It's a beta blocker. Typically, once patients start to have an impact to their daily functioning, they start seeking treatment for their essential tremor. They usually are started on propranolol or primidone, and maybe 40-50% of patients initially respond. But typically, the effect of these drugs wears off. Often, you will add a second drug on top, maybe using both propranolol and primidone, and then some subjects also move on to other antiepileptics or benzodiazepines. But really, after these drugs have been tried and failed either due to lack of efficacy or tolerability issues, there really isn't much else for essential tremor patients until they get very severe. So over here at the other end of the treatment spectrum are some neurosurgical procedures that have actually created quite a bit of benefit for the severe tremor patients. These include deep brain stimulation or things like MRI-guided focused ultrasound thalamotomy. But these are invasive neurosurgical procedures, and while they do provide some benefit to patients, sometimes this benefit wears off in just a few years. So there's really a big gap here in the middle of the treatment paradigm for the moderate to severe patients for whom there really aren't any really good therapeutics. So there's an unmet need. So Cavion is focused on the T-type calcium channel as a target, and we licensed in from Merck this molecule, CX-8998. Merck originally developed this molecule for insomnia and schizophrenia. It's actually a beautiful molecule, and kudos to the Merck chemists. They really lived up to their reputation in developing a fantastic and well-behaved molecule. But unfortunately, this molecule was deprioritized in their pipeline after the merger was shearing. So that's our luck. We were able to get this molecule. It's very, very potent, low nanomolar, very, very selective for the T-type calcium channel, and also selective for the inactivated state of the channel, which is thought to be enriched in pathologically firing neurons. And the T-type calcium channel, I don't have time to tell you all about the mechanism of this target, but it's very important in driving the initial upstroke of the action potential. So the opening of the T-type calcium channel is actually a trigger for later ion channels involved in the action potential. So this molecule has been investigated in human clinical proof of concept, proof of pharmacology study, which has been published showing, which really showed an effect on pharmaco-EEG and helped guide us to choose our dose. It's also shown some really nice results in preclinical models, which we've presented here and elsewhere, and has excellent safety margins and a good and growing safety database of 250 patients with good safety and tolerability. And today I want to tell you specifically about the proof of concept study in essential tremor. So this was a randomized, double-blind, placebo-controlled proof of concept study in patients with essential tremor. This was a learning study. The objectives of this study were really to provide Cavion with a go, no-go decision for later stage development in essential tremor. So we were looking for evidence of efficacy. We were looking for an understanding of our patient population, an acceptable safety and tolerability profile in this patient population, and insights into dose response relationships. As you can see, this is a two-arm study. Patients who were eligible were randomized to either titrating doses of CX-8998 from 4 mg BID for a week, 8 mg BID for another week, and then the target dose was 10 mg BID for another 2 weeks, or to placebo. There were a number of visits throughout the study. Most importantly, there was a baseline visit at day 15, which is steady state 8 mg BID, and at day 28 here, steady state 10 mg BID, we did efficacy assessments. The patient population was males and females, 18 to 75 years of age, with moderate to severe essential tremor that had been diagnosed prior to the age of 65. We used criteria to ensure the subjects had moderate to severe disease, basically requiring a certain cutoff of tremor severity based on a tremor amplitude as measured by the Tetris Performance Subscale, which is a essential tremor specific measure of tremor severity based on amplitude. We allowed up to one concurrent anti-tremor medication. And however, we did exclude the use of primidone because CX-8998 is the potential to become a victim of a drug-drug interaction by primidone, and we also excluded surgical interventions. So the study enrolled 95 patients in about 10 months at 25 sites in the United States only. We had quite a bit of trouble initially with screen fails, primarily because we needed to educate our investigators on sort of what constituted moderate to severe disease. Towards the end of the study enrollment, we actually had our screen fail rate down to about 10 or 15%. You can see our cohort was older with a mean age of 65, generally half and half male and female, generally white and heavy. This cohort of patients had been living with tremor for on average of 23 years, definitely an experienced population. About 2/3 of the subjects were taking a concurrent anti-tremor medication, the majority of which was propranolol or another beta blocker. There was a little bit of an imbalance between the two treatment groups with respect to anti-tremor medications. And in terms of baseline severity, here again, this is the tremor amplitude measuring score, the TETRAS performance subscale. We actually rated this 2 different ways, either through a video, centrally rated through a video, or by the site investigator. And so you can see immediately, and I'm going to point to you a little bit later in the study, that there was definitely a difference between or a lower scoring associated with the centrally reviewed data. As expected from an active CNS drug, there was a few more discontinuations in the active group versus the placebo group. So here's our scorecard. This is really the bottom line results of the study. So I have to tell you right off the top, the study missed its primary endpoint. We measured change in tremor severity based on tremor amplitude by the TETRAS performance subscale, selected as the primary endpoint as rated by the central video rater. Unfortunately, we did not see a separation from placebo. However, we measured the exact same test that was conducted, that was measured by the investigator. We actually saw a statistically significant difference. We've done an extensive analysis of the reasons for this difference, and we believe that there are a number of factors that played in, but one of which was the sensitivity of the video to detect small changes in tremor amplitude. We believe that there were some issues with our process and with the videos themselves that made it very difficult for our very experienced central raters to detect small differences. But as you can see from my title, we're still declaring proof of concept here, and the reason is because just about all of the other secondary and exploratory endpoints we looked at showed some evidence of efficacy. So we saw a statistically significant difference, and this is a 28-day study on activities of daily living, a patient-reported outcome based on things like eating, drinking, brushing your teeth, grooming, other things. The TETRAS total score, which is the addition of the performance subscale and the ADL, very, very interesting. The clinical global impression of improvement, a very coarse clinician-rated scale of improvement was highly significant. We also saw some trend towards significance at day 28 for the patient global impression of change that was actually statistically significant with a 0.004 at day 15. We also looked at personal goal attainment as well as spirography, which is drawing of a spiral, the pen and paper. So I'll show you a few of these data points very quickly. So here's the difference from day 15 and day 28 on the TETRAS activities of daily living score. So you see we're having an effect of about 4.5 points, which by our data is a clinically meaningful improvement in reduction of the impact of tremor on activities of daily living. And you can see both from the CGI-I, we had significantly more subjects improving, both by the CGI-I at day 28, as well as the PGI-C at day 28. And also, these similar trends appeared at day 15. And finally, the drug was fairly well tolerated in this population. There was a roughly similar number of adverse events reported across the two groups. There was only one subject who reported a serious adverse event. The subject had alcohol poisoning with suicidal ideation. It turns out the subject had a history of alcoholism and suicidal ideation that they failed to disclose at screening, and this manifested later in the study. There were 2 subjects who reported severe adverse events that were not considered serious. One was a syncope 23 days after completion of study drug. One was a lethargy, sleepiness, after the first dose of the study drug that was fully recovered with no sequelae and within 3 hours. And there were more discontinuations in the treated group, the 8998 treated group. The most common adverse events were CNS and psychiatric related. Dizziness by far the most common, followed by headache, disturbance in attention. We saw some euphoric mood, some hallucinations that are more like aura or illusions, and some insomnia. So to sum up, essential tremor is a serious and progressive disease that impacts daily functioning. There's a high unmet need for moderate to severe tremor treatments. 8998 is our potent selective T-type calcium channel modulator, which we tested in the TCOM study, which was a learning study, to try to provide a go, no-go decision for moving forward. And although we missed the primary endpoint, we think we see good evidence of efficacy across our exploratory and secondary endpoints, along with a benign safety and tolerability profile. And based on these results, we're moving forward into later stage development. And I'd just like to acknowledge the patients, the investigators, the Tremor Research Group, the International Essential Tremor Network, and the Cavion team for this work. And I'm happy to answer questions if there's enough time.
I think we do have time for one question. So I have one. So as you move forward, are you going to continue to look at efficacy in patients who are being co-treated with other agents? Seems to me you may be missing an opportunity to know what your drug really does.
You're absolutely right, and as part of this work, we've done an extensive pre-specified as well as post-hoc analysis of efficacy and safety, minus and plus concomitant meds. And I think we would agree with your suggestion that moving forward, we actually intend to test the drug in the absence of concomitant anti-tremor medications. We think that'll give us a better chance of seeing both improvements in tremor amplitude as well as activities of daily living.
Thanks very much. The next presentation is by Dr. Joseph Hull. The title has changed. It's SPN812 Phase 3 Top-Line Results, Evaluation of the Efficacy and Safety of SPN812 Extended Release Viloxazine in Children and Adolescents with ADHD. Dr. Hull.
Thank you very much. And thanks to ASENT for inviting us to present this really exciting results. Again, I'm presenting a summary of top-line results from 3 Phase 3 trials evaluating the efficacy and safety of extended-release viloxazine, SPN812, which I'll refer to as 812 strictly throughout, in children and adolescents with ADHD. Here is my disclaimer. SPN812 is a structurally distinct bicyclic, not tricyclic or tetracyclic, but bicyclic serotonin norepinephrine modulating agent. Viloxazine was previously approved for depression in Europe, and it was marketed for over 20 years. Supernus has developed a once-daily extended-release formulation of viloxazine, 812. A Phase 2 trial of 812 in children with ADHD showed positive results. And thus, Supernus has conducted 4 pediatric trials, Phase 3 assessing the efficacy and safety of 812 in the treatment of ADHD. We have 2 separate trials in children ages 6 to 11. And as you can see here in the table, the 301 trial and the 303. And we have 2 separate trials in adolescents ages 12 to 17, our 302 and 304. And I'll note and mention again that our 304 trial recently completed, and the results are still pending to be released, and so it wasn't time enough to add them to to this presentation. Each trial was a randomized, double-blind, 3-arm, parallel, placebo-controlled, fixed-dose trial. Thus, there are 3 fixed doses. There's 2 different fixed doses within each trial. So, for instance, in 301, there's placebo, a 100 milligram arm and a 200 milligram arm. In the 303, we have a 200 and a 400 milligram arm. And then in the adolescents, a 200 and 400 milligram and a 400 and 600. So notice that across the trials, we have 3 treatment groups at 200 and 3 at 400. Subjects were dosed once daily in the morning. 812 was supplied in a 100 milligram capsule or matching placebo for children. Children began dosing at 100 milligrams a day during week 1. If they were up to a higher dose, they titrated up at 100 milligrams per week, if necessary, to their target fixed dose. 812 was supplied in 200 milligram capsules for the adolescents. And again, they began dosing at 200 milligrams during week 1 and titrated up at 200 milligrams a week to their target fixed dose if they were up at the higher dose. You'll notice that the durations of treatment are varied, but that's basically because of the capsule unit dose and the maximum target dose. So that titration was 1 week for the trials that had lower doses, the 301 and the 302, and then in the 303 it was either 2 to 3 weeks in those trials. And then the maintenance period at the fixed dose was 5 weeks in all 4 trials at their fixed dose. The primary endpoint was the change from baseline in the ADHD rating scale per the DSM-5 total score at end of study visit. The key secondary endpoint was the clinical global impression of improvement, the CGI, at end of study. And please note that the N in the 301 trial, the target N that we were looking to study was a bit higher than the other trials, and that's based on the effect size that we noticed in our phase 2 trial. So we powered it higher for that trial, for the 100 milligram dose. Regarding eligibility, again, males and females between the ages of 6 and 17 years of age. At screening, they had to have a prior diagnosis of ADHD per the DSM-5 criteria. ADHD diagnosis was confirmed by the mini-kid. The cutoff for ADHD symptom severity at screening included the ADHD rating scale total score that had to be greater than or equal to 28, and the same with the CGI score had to be greater than or equal to 4. Subjects had to wash out ADHD medication for at least a week before baseline or randomization. Subjects could not have any history of psychiatric or neurological disorder, systemic disease, and any suicidality in the last 6 months. So here is a table showing the statistical results for the primary and key secondary endpoint for each of the 812 treatment groups compared to placebo. So you'll notice that the N here in the 301 trial in these 2 dose groups is higher than these, just to note that. Also note that the change from baseline is relatively similar across each of the dosing groups across trials, and that we saw a significant difference between placebo for the change in baseline and the ADHD total score in all dosing groups. In the same respect, the 2 subscales of the ADHD rating scale, hyperactivity and impulsivity score, and inattention score, the changes from baseline were relatively similar across the treatment groups and even between, so there was an equal change between both subscales of this scale. And we also saw a significant difference compared to placebo in each treatment group across all 3 studies. In addition, the CGI, our key secondary endpoint, we also saw a similar change at a similar mean score at the end of study visit across all treatment groups in the study, and that was significantly different from placebo at the end of study visit. So this graph is showing the mean change from baseline in the ADHD rating scale, total score over time by study group, but I'm going to just start off at showing the first graph of the 301 children, where we have placebo, 100 milligram and 200 milligram treatment groups. And you'll notice that in the first week, there was a significant difference in both treatment groups compared to placebo. It was significantly different at every weekly visit, especially as I noted before, at the end of study visit. There's a very large trend in improvement going down compared to placebo. In the 303 study in children, where you can actually notice the difference that this is a 6-week treatment and this is 8 weeks. There was 3 weeks of titration, but note that there's a separation, just like you've seen in the 301, between the treatment groups and placebo, although it was significantly different only in the 200 milligram group at week 1, and the same at week 2. But both treatment groups showed significant difference from placebo, particularly at the end of study visit, for the last 4 weeks compared to placebo. In the 302, in the adolescents, we also saw separation within the first week. It was only statistically significant for the 400 milligram group, but at all subsequent visits, it was statistically different compared to placebo across each visit, especially the end of study visit. One thing I also would like to note is if you look at this was a multi-center study, and notice that the placebo response that we see here is relatively similar across trials. And on to speaking about adverse events. These are study medication-related AEs that were observed during the trial for each of the 812 treatment groups. The most common was somnolence, which in each treatment group, at least 5% of subjects in those groups reported somnolence, although it never exceeded 15% in any treatment group, as well as overall across all 3 trials. The second most common AE was decreased appetite and headache. This was less common across all the treatment groups. It occurred at least in one of the trials at certain doses. But again, overall, this never exceeded 15% in any treatment group or overall across the trials. And fatigue and abdominal upper pain and nausea were less frequent across these trials. Also, the number and percentage of subjects that discontinued due to these related AEs was relatively small. Overall, it never exceeded 5%. So in summary, 812 significantly reduced ADHD symptoms in children and adolescents. The primary and key secondary endpoint was met in each SPN treatment group. SPN 812 reduced ADHD symptoms as early as the first week. SPN 812 was well tolerated, allowing to the discontinuation rate that was less than 5% overall in the across trials. And again, most frequently reported AEs were somnolence, headache, and decreased appetite, followed by fatigue, nausea, and upper pain. Abdominal upper pain. And I did not mention before, but most of these AEs were mild or moderate in severity. I would like to thank the patients and their families for participating in these trials, as well as the study sites and the PIs who participated as well, and our Supernus clinical team who have worked on this trial since it started. I'd also like to thank ASENT for giving us the opportunity to come here and present these data. Thank you.
We do have some time for questions. So I'm not familiar with the rating scales. What do the patients look like when those curves drop down, as they do with treatment? Is it an obvious functional change that?
So the ADHD RS5 is a structured interview that the PI conducts with the parent. So usually it's a conversation, and it assesses the 18 symptoms from the DSM-5 for ADHD. So it's basically an interview with some lead questions about
so
changes.
those changes, do they look like they're clinically obvious?
Well, we haven't delved in specifically into each and every, because we just received this data in the last few months, and we're still looking through it. So that's a great question.
I'm just wondering,
Yeah.
are people going to go, oh, my child's, this is really dramatically better, or
Yeah, and
is it subtle?
that's one of the questions that we're trying to evaluate within the population that we studied. Yes.
So along the same lines, was there a predefined, minimally clinically important difference that you had to achieve in order to be successful, or was it just significantly different from placebo?
Yeah, the latter. Yes, it was a latter difference between placebo.
Right, but was there a minimally clinically important difference on the rating scale that had to be achieved?
That's part of our ongoing analysis to determine if what's clinically relevant, clinically significant. So yes, that's a great question.
Yeah, the impetus for question from my part is just not familiar with scales, but having sat through the patient input in clinical trial session that occurred in this room earlier, that was the kind of question that was coming up. Is it something that the families and patients are going to say, oh, we really have something here?
Right.
And obviously you're thinking about that too.
Absolutely,
Yeah.
absolutely.
Well, thank you very much.
All right, thank you.
The last presentation, last but not least, I want to thank everybody in the audience in advance, and also thank Dr. Nishi. It's always a challenge to be the last one on the program, but he'll be speaking to us from Shonan Research Center on inhibition of cholesterol 24-hydroxylase, improves survival of a mouse model of epileptic phenotype, and modulates extracellular glutamate.
Thank you for introduction, and thank you for audience staying to the very last moment of the ASENT meeting, and thank you organizers for picking up this very tiny early study. And I think it is fair to say that this is purely non-clinical investigation of TTCC, although which is already in phase 2 clinical trial. So I'm going to talk about the pro-survival benefits of TTCC investigational drug actually in an Alzheimer's disease model. So in terms of disclosure, I'm employed by Takeda Pharmaceuticals, and now I'm working in Neurotherapeutics as a visiting scientist. These two companies are now jointly developing TTCC for the treatment of a rare type of epilepsy. So let me introduce the background of what is TTCC and what is this drug target. This is a small molecule inhibitor this is a small molecule specific inhibitor of enzyme known as cholesterol 24-hydroxylase. So this is a mechanism of action. This enzyme catabolizes cholesterol into 24-hydroxycholesterol, just adding this hydrogen species here. And this increases hydrophilicity of cholesterol and helping it to get excreted from the brain to the periphery. So inhibiting this step, this drug can reduce this metabolite 24-HC. And the good thing about enzyme inhibitor is we can measure this metabolite as a very specific pharmacodynamic marker indicating enzyme inhibition. And more importantly, this metabolite is excreted from the brain to the periphery, so that we can measure this in plasma in humans as a clinically monitorable marker for the indicating enzyme inhibition in the brain, which is, I should say, the kind of holy grail for CNS drug target. And there are not so many CNS drug target that allows this level of specific target engagement marker we can monitor in humans. And this metabolite is also known for a couple of different biological activities in the brain. starting from the positive allosteric modulation of NMDA receptors, and this metabolite is also known for some other activities, including inflammation and some of the things, also known to bind to ROR nuclear receptor as well. So we naturally hypothesize that the reducing 24-HC, this metabolite, may bring about some protective effect to the brain. And I'm going to talk about the model we selected. This is actually an Alzheimer's disease model, despite the fact that we are now developing this drug for epilepsy treatment. So why I selected Alzheimer's disease? I mean, we used to consider Alzheimer's disease as a primary indication for this drug mechanism. One reason is that there was an old study suggesting a genetic link between CH24H SNP with the Alzheimer's disease risk, and that was one reason. And interestingly, these days, there are independent research groups interested in this drug target for treatment of Alzheimer's disease by activating or increasing the expression level of CH24H, so the entirely opposite direction. So it is not just interesting to see what happens if we inhibit this enzyme target in Alzheimer's disease mouse model. So we selected APP-PS1 transgenic mouse model carrying mutations in APP and PS1. These two genes are primarily involved in production of amyloid beta. I'm not a big fan of amyloid beta theory, but this is basically a model with elevated production of amyloid beta. And but this A-beta production model is now gaining more attention, actually as a model of distorted excitatory and inhibitory balance. This model is known for age-related seizures and the potassium dyshomeostasis, meaning impaired reuptake of potassium from the extracellular space. And also, this model is known for high mortality related to seizures. So this model can be seen as a model of a sudden unexpected death of epilepsy. And most importantly, from my perspective, there was a 2009 publication from Dr. Russell demonstrating that the crossbreeding of APP-PS1 model with CH24H knockout actually resulted in a significant extension of the model's lifespan. So we hypothesize that treating this APP-PS1 model with TK935 will bring about survival benefits as well as the improvement of their epileptic phenotype. We treated APP-PS1 mice with 935 for 2 weeks, and we looked at the extracellular glutamate levels in hippocampus with microdialysis, and in a separate cohort, we looked at survival observations. The reason why we looked at extracellular glutamate is that there was another publication in 2010 suggesting that overexpression of CH24H in astrocytes actually negatively impacts their glutamate reuptake. This is a purely in vitro experiment, but it's suggesting the detrimental role of overexpressed CH24H in astrocytic function of glutamate reuptake. So for that reason, we looked at extracellular impacts on extracellular glutamate level in hippocampus. So this is the result of a glutamate microdialysis study. We use a high concentration of potassium to evoke glutamate release, and as well as the epileptic behaviors. I should say the seizure behavior, including wild running, jumping, and tonic extension seizures. So with KCL perfusion into the hippocampus, APPPS1 mice show a massive elevation in extracellular level of glutamate, as shown here, compared to wild type. And this elevation of glutamate was accompanied by severe seizure phenotypes, so we had to stop this experiment for humane reason with the 60 minutes of KCL perfusion to prevent the loss of animals. And importantly, there was no difference in baseline of glutamate comparing a wild type and mutant. And when we treated APPPS1 mice with TTYpe, the elevation of glutamate evoked by potassium was beautifully suppressed, like shown here, and the seizure behaviors in APPPS1 mice were not seen in drug-treated animals at all. And so this brings me to the last slide. In a separate cohort, obviously, we looked at the survival curves for 2 months. The left-hand side is from the genetic ablation study of CH24H. As I mentioned, Dr. Russell reported this very interesting observation where they demonstrated the extended lifespan of APPPS1 model with crossbreeding with homozygous and heterozygous knockout of CH24H. These two knockout mice show a same level of survival benefit. And for that reason, we selected the dose of TTYpe achieving just about 50% of enzyme inhibition. And we treated mice from 7 weeks of age, and we observed obvious separation of survival curve and bringing about significant survival benefits in this Alzheimer's disease mouse model. And basically replicating the observation done in a genetic study in mice. So that said, I will summarize the finding here. First of all, we found that the APPPS1 mice is super susceptible to glutamate elevation with the stimulation of high concentration of potassium, releasing a catastrophic level of glutamate leak to the extracellular space in the hippocampus, leading to a lethal seizure. And this phenotype was robustly addressed by treatment with TTYpe for 2 weeks. So I have not reached to the point where I can talk about the mechanism behind these effects, but considering the model, I would suggest that the CH24H inhibition may have something to do with the potassium regulation or release or reuptake of glutamate. So that is a hypothesis I'm now thinking about. But that said, I'm going to stop here to take any questions if time allows. Thank you for attention.
Have you looked at the compound in stroke models?
Right. It may be inappropriate for me to say that, but there are many companies that are allergic to drug development in stroke with a long list of failure in trials. Yeah, that's a very valid point, and that is what I'm still very interested in.
Well, if there's no further questions, thank you very much, Dr. Nishi, and thanks to you, audience and ASENT attendees, for your perseverance and participation in the meeting, and this officially brings it to a close. Hope to see you next year. Thank you very much.